So walking is really good, actually. Unless, of course, walking is vigorous and too prolonged and too difficult, which raises your demand above your capacity, then it's bad. So it's a very touch and go issue as to whether walking is good enough to help you or too much because you exceed the supply-demand issues. This is our stroke line. I think stroke line is even more impressed. I mean, it's not uncommon to see a 60 cc stroke volume, and normal is 115. So right off the bat, you're looking right at the problem. Is their ventricle fills with half as much blood as normal because there's no energy in it. Cardiac output, stroke volume times heart rate. The measurement techniques, the Fick method, which depends on VO2. Therefore, anybody that has a consistently low oxygen consumption should be suspicious for output problems, which we've already shown that you have. If you're not utilizing oxygen, you probably have a mitochondrial dysfunction, at least possible, and we showed the lactate peak in the brain. Dilution method is invasive impedance cardiography is what this study is about. Ultrasound can measure output, but not accurately. It's not as accurate as impedance cardiography. Brute force approximation. Cardiac output equals the pulse pressure, which is the difference from systolic to diastolic, times 2, which is your stroke volume, times your heart rate, is cardiac output. It's called a brute. So if you want to sit there in your chair and calculate your approximate cardiac output, you can do it by knowledge of your blood pressure and knowledge of your heart rate. That's really all you need. But what's in the number? The cardiologists that I speak with at Duke tell me that you can have two people both at 3 liters per minute. One's okay and one's dying. So it's not just in the number. It's what their body needs, their relative metabolic rate, what they're doing, and what's happening as a compensatory mechanism to make them 3, which if they did not have, they would be 1. Understand? Without some compensation, they could be 1, but they're sitting at 3. That's a much sicker person than someone who's not compensating at 3. So a number is not where this is at. So people, it's very important that you not go out and say, well, my cardiac output is this or that. That's not necessarily the whole thing. Cardiac output very much depends on body position, level of activity, with a range of a whopping 4 to 25 liters a minute. And that's what normal people can go from 4 at rest all the way to 25, and that's really the normal range. It's astonishing, is it not? Sitting at rest, feet down, normal is 5, according to the textbook of medicine. Supine or sitting at rest, feet up, it's 6 to 8, average 7. Standing, it's 5. Level walking, it's 6 to 7. And running is 15 to 25 liters a minute. How in the world does a heart go from 5 liters a minute to 25? By the way, Lance Armstrong, 35 liters a minute. He's the best that's ever been measured, 35 liters a minute. So how can we do this? And it's done with adrenaline, primarily. You run on speed. Adrenaline from your sympathetic nervous system. That's what causes this dramatic range difference, is speed. Enormous range of cardiac output is primarily due to the level of adrenergic tone or adrenaline produced in the adrenal glands and sympathetic division of the autonomic nervous system controlled by the subcortex. Adrenergic tone affects cardiac output by A, increasing myocardial contractility or force, B, increasing heart rate, and C, increasing venous tone and therefore preload. Of these, interestingly, the most critical one for our patients is actually C. For diastolic dysfunction, the most critical compensatory mechanism is C. And guess what kind of patients cannot get C? Those in chronic pain, which suppresses the vasomotor tone supplied by the central nervous system. Therefore, one of your principal compensatory mechanisms against this is taken away from you. And that's a big problem because your diastolic dysfunction could look relatively mild, but if this is removed from you, you can't have output. Which is why the cardiologist can make a mistake to assume that minimal diastolic dysfunction has no meaning. Purpose of cardiac output is to supply adequate microcirculation to organs and tissues and to maintain the supply-demand ratio at 1 or better. This is a very important statement. Maintain the supply-demand ratio at 1 or better. The demand for microcirculation must be at or exceed the supply, or at or below the supply, I should say. At or below. Microcirculation provides oxygen and nutrition. It provides cell signaling hormones and peptides. What good is thyroid hormone if it can't get to the cell to bind to it? Think about that. My thyroid hormone is normal, but my doctor says I'm hypothyroid. Well, actually, he may be right, except the problem isn't thyroid. It's that you have no microcirculation to get it to the cell. Tissue immune surveillance. I'm an example of that. No immunity exists without microcirculation. Avenue for cellular waste and toxin disposal. What would be the consequence, probably the most important consequence, of inadequate toxin removal from normal cellular metabolism? And the answer is pain. If you want to guess what causes pain in general, it's basically toxic buildup in a situation where you can't remove it. A paragraph in Guyton's textbook of clinical physiology states that if the supply-demand ratio, if the demand exceeds the supply by even a very small amount, estimated at maybe 1 or 2%, and the aggregated decrement reaches 120 cc's of oxygen, the LD50 is the LD50 that half the patients with that scenario will die of that. That's what it says. It says it's not a time increment issue. It's just that over any given time, if the sum decrement of supply-demand ratio sums up to 120 cc's, half of you will die of that. That's an incredible statement. You should read it. Because I've thought it long. In fact, I stayed awake at night because I read it last night, and I stayed awake thinking about what this could mean. Most of you are consuming 25 cc's of oxygen per kilogram per minute. That's what you're consuming at rest. 22 cc's of oxygen per kilogram per minute. 22 to 25. If you were, as long as you're matching your demand to that number, you're going to be okay. But if your demand exceeds that number by even a very tiny percentage, and you sustain it for any length of time, even a small time, 30 minutes, it'll kill you. That's what the textbook says. Therefore, what can we say about this, since none of you have really died per se of this? Then what does this say? It says that you never exceed the demand. You never exceed the supply. You never do, metabolically speaking. So there's an exigent requirement for life that any reduced supply of blood demands a reduction in metabolic rate, without which you're going to die. So how do you reduce metabolic rate? Well, one thing is you can reduce your thyroid hormone, which is in fact what's happening, I believe. But one of the biggest things you do is you reduce the metabolic rate of your lives. You reduce the metabolic rate, you reduce the demands placed on your life, functionally speaking, so that you don't die. So the reason CFS patients are dysfunctional is they're just trying to keep themselves within their supply, because they'll be held to pay if you don't do that. Of course, that misses one point, and that is okay, well, if I get up and walk across the room, I'm increasing my supply. How do I get my demand? Remember the output went from 5 to 25? 5 liters a minute, 25 liters a minute. You get it from speed. You get it from adrenaline. So the reason you get up and march across the room and not die is because you just had a big shot of adrenaline. That's how you're living. You're living on speed. And God help you if you run out of it. We call that adrenal exhaustion. So another factor besides pain that could heavily limit you is if in the course of this disease you run out of enough speed to live your life on.